So again, ER nursing or ED nursing is knowing a lot or a little bit about a lot. You don't have a whole lot of idea how your patients are going to look when they arrive. You're doing quick, focused assessments around the problem, not going real in depth into, every single possibility that could happen. They're really just looking at what's the problem, how do we diagnose it, how do we fix it, and get them to where they need to be for continued care. So ED is a really kind of a landing zone, a diagnosis zone, and the focus is to get them to where they need to be as quick as possible. So the first and the biggest part about ED that's different than most of the other hospital areas is the triage and assessment. And for your exam and for what I'm going to expect you to know from triage and assessment are the two tools that we use to triage and assess people. One of them is more EMS field related, so for our disaster scenario, and one is the ED actual, what the triage nurses use in the ED. So basically triaging is just figuring out who gets to go first. And so it's very similar to all of your prioritization, actual versus potential problems, expected versus unexpected. And the ED also uses what resources are you going to need? Are you going to need just labs, or are you going to need diagnostic, CT scans? Are you going to need other interventions? So they kind of take all that into consideration when they're triaging you. So we have two tools that I am going to ask you to be familiar with. The START triage is our very basic kind of disaster triage, and then there's the emergency triage. You can use both tools. I do believe during disaster day, the first quiz is taking all four of, I think it's 6 patients and triaging them according to the disaster triage, the START triage. It's called Simple Triage and Rapid Assessment. It is START. You probably, if you've already done your critical care clinical, day 3, you did get to go in and do the turbulent sky scenario where you did disaster triage. So hopefully everyone's had a little bit of experience with it. And then the standard emergency triage is what the actual EDs do use. The Emergency Severity Index. So looking at the START triage, this is the color code system, and you tag patients based on their needs for services. So red is the most urgent, the first priority patients. They have life-threatening injuries, so ABC injuries. That need to get, so if you're transporting from a disaster scene, these patients get lifted out or get to go first because they have injuries that need to be treated right away. Yellow patients are second priority. They're urgent. Doesn't mean their needs are not important, but they are second priority. They're injuries that have systemic effects, complications, but could wait a half hour, an hour. So again, life-threatening, second priority, urgent, we need to get you to a hospital, but not right away. And then green is, they could wait a couple of hours for treatment. And then unfortunately black is expectant or deceased. So let's look at, this is the START triage tool, and this is what we're really going to be using, and it is an ABCD, triage, basically. You are looking at the patient first. Are they able to move around? If they're able to move around, they immediately go to green. If they're able to move around, then we will put them to green, and that's it. They're done. They're green. Whether they have, possible potential problems for later, we'll deal with those later. We're really going through, and this is where what EMS and police are trained to do when they first arrive at the scene of a disaster is to quickly assess. And if you are talking and walking, you get moved to green. And they will deal with you after they've dealt with all the red and yellow patients. To further look at a patient, so the patient's laying down on the ground. To further look at them, you go, airway. Are you breathing? Are you breathing? Do you have a respiratory rate? If they are not breathing, if there's no noticeable breaths, and the quickest way to look for breaths is to count for seconds. If you are counting a breath every 5 seconds, you are breathing about 12 times a minute. If you're breathing every 4 seconds, you're breathing, what is that, 15 times a minute. So like you can kind of guesstimate. I like to make sure that my patients are breathing, taking a breath every 5 seconds or so. That is the minimum that they should be breathing. If you're breathing every 10 seconds, you're only breathing 6 breaths a minute. If you are breathing every, let me think, what gets you to 10 breaths a minute? Is that every 6 seconds? Every 6 seconds gets you to 10 breaths per minute? Yes. So actually, we've got to be breathing better than that. If you take a breath and then you don't take your next breath for 6 seconds or longer, you are not breathing fast enough. But what we're looking is for spontaneous breathing. So you're looking for a breath of any kind whatsoever. If you are not getting a breath of any kind whatsoever, then you reposition the airway, straighten out their head, see if you can get them into a sniffing position, get them repositioned, and do they have any breaths? This is not 1 breath per minute. It says spontaneous breathing. According to this one, there are some START criteria that define agonal breathing as less than 4 or 6 breaths per minute. For this one, it's just any breathing at all. You qualify for spontaneous breathing. Apnea, and I do believe I looked up apnea at some point, the definition of apnea and agonal breathing. And let me clarify that right here, right now, because this was an issue last semester. Agonal breathing. Let's just double check that real quick. A couple of, I think, when people were asking for expectant versus immediate, I had a respiratory rate of 4 on one of the patients in one of the scenarios. A respiratory rate of 4 is every 15 seconds and technically meets the definition of apnea. One definition I have on apnea is a cessation of breathing for 10 seconds, and apnea can last for 30 seconds or even longer. So I would think that any respiratory rate less than 6 is going to get you possibly apneic or agonal respirations. Now, I will leave this up to, I myself would have a hard time walking away from someone that was doing agonal respirations. But if you have 15 people and 10 of them are red, then that patient that's already apneic or breathing every 10 seconds or less, it would be considered expectant. Does that make sense to people? So I think what I'm going to put on here for my testing purposes may not be for everyone's purposes. Oop, what did I do there? Hang on. How did I end up with 2 of these? What I'm going to do here for apnea is a respiratory rate less than 6. Is everyone okay with that definition of apnea? A respiratory rate less than 6 a minute. That's basically taking a breath every 10 to 15 seconds. So the patient that has a respiratory rate of 4, they are going to be expectant, meaning that death is imminent, and they would be left behind, unfortunately, in this situation. Still hearing me? Still good? Processing that info? Okay. So I do want to kind of clarify that because that was a concern for a couple of the questions, and I wanted to make sure that we did make that clear, that apnea does have a definition. It doesn't mean 0 breaths. It means breaths that are not consistent with providing oxygenation to the body. We're supposed to bag patients that have a respiratory rate less than 12. And so a respiratory rate less than 6 or breathing 4 to 6 times a minute is not compatible with breathing enough for life. So we're going to leave that at that. Again, you will probably find people that would argue that, but apnea, we would leave someone behind that is only breathing 2 to 3 times a minute, maybe 4 times a minute, because they're just not, we're not going to be able to get them help quick enough, especially if there are other people that are in the red that we need to transport. And so they're looking at, triage is not nice. Triage is meant to provide services to people that would benefit from the services. And so in disaster, if you do roll up somehow on day in a disaster scene, you would keep reviewing patients, and you would keep looking for people who are red. Apnea, for my purposes, for the testing purposes, would be anything less than 6 breaths per minute. So if they're breathing 2-4 times a minute, that's considered apnea. So basically, are they breathing? Are they breathing well enough? If you can get them breathing more than 6 breaths per minute, well, you don't need bag mask support, then you can put them in the red category. If they're breathing less than 6 times a minute, we put them in the expectant category, that they're expected to die soon. They just have some vestiges of life left. So that's how you can go right to red, by not having an adequate respiratory, that you are breathing, but it's not quite adequate enough. You can also get put into red by having a respiratory rate that is too high. That's indicative of hypoxia as well. We learned tachypnea is indicative of hypoxia. So if you are breathing, and you are breathing 6 to 30, then you're in the red spot. Or even, I guess, anything over 6 would get you into red at this point. You are still considered red, and we're going to keep looking. Okay, so anything above 6, we're going to consider you red. We're going to go on and look at perfusion. Okay, the perfusion patient, are you perfusing? And what, we're not going to pull out a blood pressure cuff, because most people showing up on disaster scenes don't have time to take blood pressure. We're checking a pulse. Do you have a radial pulse? You need a blood pressure of at least 80 to mount a radial pulse. So when you're doing a radial pulse, you are saying my blood pressure is probably greater than 80. If you cannot get a radial pulse and the cap refill is prolonged, then you have perfusion issues. You stay in red. If you pass the perfusion test and you have a radial pulse and you have a cap refill, then we'll go on to look at D, which is, I like to call D delirium, but it's really D is your mental state. I don't have a good D word that defines mental state other than delirium. Why is it having trouble? No, the recording shouldn't be paused. I have my recording as recording. Am I pausing my internet maybe? My recording is still going. All right, so where were we? So we're doing an ABC check. We are looking, the only way to fall off of the radar at this point is to have a respiratory rate less than 6. We're checking airway, we're checking breathing, we're checking circulation. We're keeping everybody in red until we get into the following commands. If you are not able to follow commands, then you stay in red. If you're able to answer questions, you now get moved. You have an airway, you're breathing, you're circulating, and you are following commands. A, B, C, D, check out. D is for mentation, so airway, breathing, circulation, and D is for mentation. I don't know if someone comes up with a good D word. I call it delirium because it reminds me of the brain, but it doesn't mean we're checking for delirium. It means we're checking for mental status. So when we're doing A, B, C, D, the D is for mental status. Level of consciousness following commands. Because that's our next perfusion check, is our brain. So if you do not meet any of your ABC criteria, your respiratory rate is too high, your perfusion is not good, you stay red. If you are respiratory rate less than 30 and your perfusion is good and you can follow commands, you go to yellow. So that is a quick look at people as you're stopping and talking to people. If they're talking to you, you don't even need to do the ABC check. If they're talking to you, then you just need to do you put them into yellow. If they're mentating and following commands, they go to yellow if they can't walk. So when you're walking up to people, you can ask them, can you get up and move? If they say no and they're talking to you, then they just go to yellow. Okay, you don't need to do the airway breathing circulation check fully. They're going to go to yellow. If they don't answer you, you walk up to them and you say, or they're not answering you appropriately, and you say, can you get up and walk? And they maybe mumble something, then you're going to do the respiratory rate check and the perfusion check. And the reason we're doing these things is that we're looking for signs and symptoms of lethal problems, which we're going to go through. We're looking for cardiac, the big problems that you're going to have in a disaster scenario are you're going to have thoracic trauma, abdominal trauma, or large bone fractures. And those are going to keep you from able to walk around. If the patient can get up and walk around, we move them to green. Otherwise, we're checking their pulse, checking their respiration, and asking them if they can follow commands. But that will get you into your reds and yellow categories. If you're just using regular triage in an emergency room, the things that I probably want you to pull out of this one are your danger zone vital signs, and I'm only interested in your danger zone vital signs for an adult. I'm not taking care of a peds patient. So we want our danger zone vital signs, which are heart rate greater than 100, respirations greater than 20, and a SAT less than 92. If you have one of those danger zone vital signs, then that triages you to at least a level 3. Okay. So what they're looking for is if you have the danger zone vital signs, you're going to be at least a level 3, possibly a level 2 or a level 1. What's going to increase you or decrease you on those levels is how many resources are needed and your mentation. So you come in with a heart rate of 100 and a respiratory rate of 12 and a SAT of 96, you're going to 4 or 5 and you're waiting in the waiting room. Because what they're going to look at is you're not in the danger zone vital signs. You can wait for a few minutes, and then they kind of take a look at you on, do we just need to do a quick blood pressure check, maybe give you a little fluids and draw some labs? That would be one resource. Do you need possibly x-rays or things like that? That will get you multiple resources. If you do not have danger zone vital signs, though, you're triaged at a level 4 or 5. If you have any danger zone vital signs, you get immediately triaged up into 3. And then if you are in having high-risk situations or you're having mentation problems or severe pain, they'll move you up into 2. And if your immediate life-threatening issues, which we'll talk about, would be cardiac, respiratory, ABC problems, then you'll go to level 1. Does that make sense to people who have been in the ER? And if you have not been to the ER, I will tell you that you need to wait. My mom would tell me, are you really sick? Which means, do you got danger zone vital signs? Because if you're not, we're not going to waste our time going in level 4, level 5. Those patients can go to urgent care. If you have danger zone vital signs, a high heart rate, high respiratory rate, again, are compensatory signs of shock, then you may go to the ED and you'll be triaged with a yellow, red, or blue as needed. Make sense? Any questions before we move on? Those are our tools for triage, and that is what our ED is doing. Kind of going back to disaster again, there are 2 kinds of surveys, the primary survey and the secondary survey. So what I'm going to tell you is that if you are doing a primary survey, you're doing a very basic ABCD. Oh, disability, D for disability. But I don't like disability, all the time. Because I don't know, disability could be a broken leg or anything. It should be mentation. The D part should be, is your brain, are you following commands? Are you awake? Are you alert? Are you following commands? That is the D part of the assessment. So when we're doing the START triage, we're doing a primary survey. Note that we did not take any blood pressures. All we're doing is a respiratory rate and a pulse in the primary survey. It's to identify life-threatening conditions, we want to make sure there is an E in there, which is exposure, making sure they're not hypothermic, covering them up with a blanket if they're getting cold, making sure that they're in a safe situation. So that is exposure and environment. Demented. Demented could be, dementated. Anything that works with D, I think disability is the official word for ABCDE, disability, but again, disability throws me off because I think, moving disability. So demented or dementated or whatever you want to think of, that's what we're looking for in the D. So when you're looking at a primary survey, we're looking very superficially, something like the START triage, where we're just making sure they have an airway, you're breathing adequately, and you have a pulse. We're not doing vital signs in the START triage or in the primary survey. The secondary survey is everything else. This is where vital signs are, a head to toe, taking a look at the back, rolling them onto their backsides, looking. So people are using good D words, disoriented. I like disoriented. How about we just call it disoriented now? Let's go in and call it, instead of disability, I like that one. Let's call it, are you disoriented? I think that one's probably means the best, and it's a D. I like that. So you could say disoriented, demented, dementation. We're looking for a lack of good mentation. So ABC, airway, just are you breathing? What is your respiratory rate? Do you have a pulse? And then can you follow commands? That is the primary survey. It is the START triage, basically. There is one more. The E means exposure and environment, making sure they are safe. So if a patient's laying in a pool of water, drag them out of the pool of water so that you could possibly defibrillate if you need to. If they're, this is where we try to extricate them from cars and do things to get them into a safe environment. So look at the environment around the patient to make sure it is safe, make sure they are warm, that they're not going to have any other complications. But it's a very quick, rapid, are you awake? Are you breathing? Are you with me? Do you have a pulse? And are you safe? Everything else falls into the secondary survey, where you've at least rapidly triaged them and you know that they are somewhat stable, they're not in expectant damage. And this is where you can turn them, take a look at their backside, see if they're laying on glass, doing a full Glasgow coma scale, more vital signs, pulse ox, those sorts of things, getting a history from them, all the other stuff. So anything other than that START triage, the A, B, C, D, E, it's basically airway, breathing, circulation, but not a full set of vital signs. Most patients in a primary survey, you don't have access to your full vital sign capacity. So in a disaster situation, we do a primary survey on everybody, get them categorized, and then you can go back to people and start doing secondary surveys where you're getting much more information on the people involved. So I think that's, and then there's the trauma center levels. Again, I'm not testing you on trauma center levels, but when we're in disaster day and when we're doing it in person, we are a level 3 trauma center, the Coyote Community Hospital. We're able to treat and stabilize patients for transfer. There's no 24-hour availability depending on how Coyote staffed. We don't even have labs sometimes when you come to SIM. So we kind of fluctuate between a level 3, level 4 facility. Really, level 3 facilities are full ERs. So when you're looking at the Phoenix area, level 4 facilities would be an urgent care, freestanding ER. It doesn't have to be rural. Places that can do evaluations, but if you walk into an urgent care and you're complaining of chest pain, they send you somewhere else. or they call an ambulance for you because they're a level 4. They can only say, yeah, you need more help and get you out. And then level 3s are most ERs on a hospital with some services, and then level 2s are able to manage critical patients but just don't have specialties, and level 1s can do anything. The level 1 centers in Phoenix area, I'm not as familiar with West Valley. I know Banner Desert and Chandler Regional right now are East Valley level 1 centers. Scottsdale is a level 1 center. Banner Desert, St. Joe's, John C. Lincoln, North Mountain, I do believe Thunderbird, maybe. I'm not as familiar with the West Valley, but level 1 centers are your destination centers. They have neuro, they have cardiac, they have vascular, they can handle almost anything. The only thing I know Chandler cannot handle would be neuro intervascular radiology. So like if you're having a brain bleed, they send those out to St. Joe's. But for trauma patients, the goal is to get them to a level 1 trauma center. They can do orthopedic surgery, they can do neurosurgery, they can do cardiac surgery, they can do vascular surgery. They have plastics on hand as well. So a level 1 trauma center has been through a special accreditation process. I'm trying to think, level 2 would be Banner Baywood, Mercy Gilbert. Trying to think what other hospitals are along the 60 corridor. All the banners along there. Level 3s would be things like the smaller hospitals like Ironwood, Banner Ocotillo that just opened. Gosh, I can't even remember all the things along the 60. There's so many of them, so many hospitals. But it's kind of good to know what level, especially if you're transporting a patient and you're doing EMS, they know what levels everything is, and you're going to get transported. If you're in the red in your primary survey, you're going to a level 1 hospital. If you're in the yellows, they can divulge you out to level 2, level 3s. And for your disaster day, we are a level 3 ED. So we have to transfer almost everybody out. Anybody that's not yellow will get transferred out. So let's look at the 5 fatal thoracics or chest traumas. Again, you know most of the interventions for these. We've covered them already, really, in your cardiac and your respiratory lecture. So this is a review. But the 5 fatal, and the reasons you're looking for tachypnea and pulses is we are looking for any suspicions of having these 5 fatal thoracics: tension pneumo, open pneumo, massive hemothorax, flailed chest, and cardiac tamponade. The only one you probably haven't heard of so far is flailed chest. So this is a 1-page little summary slide for each thing. Can also, you're like, why didn't we have this for studying? But a tension pneumo, all of these are worsening conditions. So what we are seeing is diminished breath sounds on the entire side. A tension pneumo is a whole lung deflation, basically, and is getting rapidly worse. Diminished breath sounds on the entire side. We're starting to see tracheal deviation. You're starting to see hypotension, tachycardia, because you can see the heart and the venous return is getting pushed off to the side, severe shortness of breath, accessory muscle use. And the treatment for it is to stick a needle in that dead air space. So what they are looking for when they're talking about immediate decompression, it's not a full-on chest tube. It's sticking a needle right into that dead space and letting air out. And that is immediate decompression. I do believe, let me just see if this works to go to the link. Let's see if the link works. I'm not sure if the link still works. I did not check the links in this. Let's see. Get out of the drawing. Go to the link. The link doesn't work anymore. I'll have to find you a decompression link. I liked that one because it shows the, when they did the link, sorry, you're looking at my calendar. You don't need to look at my calendar. There it is. Go away. I will find you another decompression link. But basically what they do is they put a needle on a water-filled syringe and stick that into the dead space. You don't. I think some medics are trained to do so. ER docs can do so. But you're sticking a needle into the dead space there. Remember, air rises, so they're actually probably going to go up in the upper, just like you would put a chest tube in. Any medics in the room, you could tell me the location, but I'm not going to test you on it. But you are sticking a needle into that dead space and letting air out. The reason it is good practice to do a water-filled syringe on the end of the needle, so you put in a large gauge needle and stick a water-filled syringe on it, is because air can bubble out but not get into the patient. You're making that one-way water seal valve. And so what you're doing is you're letting air out and hopefully air not back in, and you are letting that lung re-expand. The long-term care is a chest tube. You can't leave a needle and a water-filled syringe hanging out of a patient. That is just emergency to get that heart decompressed, get the vessels decompressed, and get that lung re-expanded enough that then you can put in a chest tube. So that is emergency care of attention pneumo. Then we have an open pneumothorax, which is a sucking chest wound that we were kind of hinted. We didn't even hint at an open. We didn't say there was an open wound on the test question. The test question had a blunt trauma, which is basically a bang to the chest and a bruising of the chest, but not a open wound. An open wound is a penetrating wound that is sucking air on inspiration because it's pulling air into the chest. And absent breath sounds on the affected side. This is going to get the 3-sided chest dressing. An open pneumo is the same as a chest tube being pulled out. It's a hole in the chest that's allowing air in to the dead space, and it's not exchanging with oxygen, and it's basically pushing the lung space out. Every time you take a breath, it pulls air into that space. So what that 3-sided dressing is going to do is suck up against the chest and not let air in, and then when you are letting air out, it lets air. So when you inhale, so it's a sucking sound on probably exhalation, actually. Sorry if I'm thinking about it. Go back. Because when you're inhaling, go back. Go back. When you are inhaling, your lung is actually big, and no, it is pushing air out. So that's probably right. A sucking sound on inspiration, because when you're inhaling in, air is escaping out of your chest, and then when you are exhaling, air is getting sucked into your chest. So anyway, this is a 3-sided dressing, and then long term is a chest tube to remove the pneumothorax that you have. But if you do not fix an open pneumo, you will keep pulling air into your chest and create a tension pneumo. Massive hemothorax is massive bleeding. Again, immediate decompression to let the blood out, and a chest tube is a long-term. If it's more than 500 milliliters of drainage, and sometimes some people will say even more than 100 milliliters of drainage, you would want to probably take that patient to the OR for having a massive bleed. The only time we usually get an order to clamp a chest tube is when they want to maintain pressure on the bleeder. So if this is the, let's say that you ended up with a gunshot wound and you nicked this artery and it is bleeding into the space here, the blood will actually work as a pressure dressing on the lung. So sometimes they do allow for clamping of the chest tube to keep pressure on that bleeder until they can get to the OR. But that would be an order to clamp the chest tube. So sometimes they'll let you put some of the blood out and then clamp it. Again, that is a physician's order, but a massive hemothorax will cause the same symptoms as a tension pneumothorax. A flailed chest is the one that we did not talk about. The thing to remember on the flailed chest is this paradoxical chest movement, and I do believe the link does work on this one. Paradoxical chest movement means that when you are, that the broken ribs are loose and hanging out on top of the lungs, and they actually get pulled in and blown out disproportionately. So when you are inspiring, you're supposed to be inhaling your lung, you're making your lungs bigger, but that negative pressure actually pulls in the broken ribs. And then when you exhale, your lungs are supposed to get smaller, but that piece of rib goes out. So it's paradoxical. It's not the way the chest is supposed to be moving. The loose ribs move against the chest, and that can cause pneumothoraces. It can cause air leaking out around that tissue, or air leaking into the tissues from a pneumothorax, and you get crepitus around there. The treatment is to splint the lung, and the only way we can splint the lung is with PEEP and non-invasive and positive pressure ventilation. So when they're doing that, we're trying to splint the lungs open, and PEEP and non-invasive positive pressure ventilation will help splint those lungs open. They are at a high risk of ARDS and pneumothoraces with a flailed chest. So if you're going to remember anything, if you see paradoxical chest movement, let me just see if this works real quick. If you see paradoxical chest movement, you're worried about a flailed chest, and that can cause, because you have loose ribs. Going back. It won't let me click. All right, well, check the link and let me know if it works when we get out. It's not letting me click on the link. It's just forwarding the slide. Cardiac tamponade, we've talked about in the cardiac lecture. Dyspnea, pulsus paradoxus, muffled heart sounds, JVD, basically signs of complete heart failure. And if you have a blunt chest injury, a sternal injury, any kind of damage where the heart might have started actually bleeding into its pericardial sac, if you have suspect of an injury like that, then they can do a pericardiocentesis, which is where they are actually pulling the blood out of the pericardial sac. And again, that was quick review of the 5 fatal chest trauma, and then we have abdominal trauma, which the cues of abdominal trauma, or a high suspicion of abdominal trauma, will be from the seatbelt sign, where you can see here this guy actually has a bruise the size of the seatbelt. If they have hit the chest and the seatbelt with that much force, there's a high incidence of abdominal injuries. So if you see seatbelt sign on a patient, if you have an open abdominal entry or exit wound, if you have signs of bleeding, which this is Cullen sign, and this is Turner sign. If you have signs of abdominal bleeding, this would be where we would need to investigate, or Kerr's sign, which is referred pain to the left shoulder. Anytime you have diaphragm or a spleen injury or any free air pushing on the diaphragm, Kerr's sign is associated with diaphragm pain. And so whenever your diaphragm is damaged or under pressure or being pushed against, you can have referred pain to the left shoulder. So it doesn't mean they're having a heart attack, but Kerr's sign could be a sign of abdominal trauma because something is pushing up against the diaphragm. So if you have any of those cues, it's good to do a diagnosis of your abdomen, and the quickest diagnosis of your abdomen is an ultrasound that they do in the ED called a FAST, focused assessment with sonography and trauma. So if you're coming in with any kind of trauma and signs of abdominal bleeding or a suspicion of abdominal bleeding, they can do this FAST scan. It is a quick ultrasound. It does not involve going to the CT scanner, can be done quickly, very cost effective, and detects blood very quickly. The treatment for any abdominal trauma with blood or air in the abdominal space is going to surgery. So going to do a diagnostic surgery, because probably if you have blood or air in your bowel space, you have some kind of damage to your internal organs that they need to go in and look at. So the things to remember for abdominal trauma are the things that make you suspicious for abdominal trauma. So the seatbelt sign, trying to draw, oh my goodness, and just blow through all my slides when I try to draw. The seatbelt sign, the Cullen sign, the Turner sign, the Kerr sign, all of those things would lead you to get a fast scan or a CT scan. The fast scan is much quicker and faster and more cost effective. So if that equipment is available, and most level 1 through 3s have a fast scanner so that they can do a quick assessment to see if there's anything wrong in your abdomen, which will then send you to surgery. Any questions so far? Again, quick, down dirty, 5 fatal. So if you see on any of your disaster day patients any of the 5 fatal thoracics or any of the abdominal cues, those are patients that need to be looked at pretty quickly. Large bone fractures are another pretty severe complication that we see during disasters or traumas. And when we say large bone fractures, we mean the femur and the pelvis. So we're not talking about arm or lower leg. We're talking about the femur and the pelvis. Those are our large bones, highly vascularized, and cause severe problems really quickly. One of the ways to figure is really the disfigured lower extremities. Foot on backwards disease, or FOB. If your foot is turned away it's not supposed to turn, or your foot is not attached, that is a good sign that things that you have upper bone or large bone fractures. The other thing that is a big cue of large bone fractures is hypovolemic shock. The pelvis is highly vascularized, and the femur is highly vascularized. There are main bone marrows, highly vascularized, and when they're broken, they bleed. So what we're looking for is, of course, just extremity deformity, pain in that area, but they progress to complications pretty quickly if they're not treated. Large bone fractures have a lot of internal bleeding. So we're looking to see if they have a decreased blood pressure, tachycardia, agitation, confusion. Again, all those A, B, C, D things can come from large bone fractures. One of the other complications is compartment syndrome, where the swelling from these fractures cause so much pressure that it decreases circulation to the extremities, and they're also at risk for fat embolisms from the bone marrow being broken. What we're going to do is any direct pressure for any bleeding, but immobilize the patient. Most bleeding from these large bone fractures is internal. So immobilizing the patient using any kind of immobilization that you can, splints, casts, even homemade splints, will decrease the bleeding of a large bone fracture. If it's open fracture, definitely antibiotics and tetanus, but immobilize is the number one key to large bone fractures. With pelvic fractures, they have pelvic binders and splints for pelvic fractures, and then getting those legs splinted the best you can and getting them reduced if you can, or getting them put back into place. You can kind of see on that x-ray up at the top here. This is the displaced fracture, and this is the replaced fracture. You can see when a bone is displaced, it's basically ripping muscles, tendons, vessels. It's a jagged edge of bone that's now loose and wreaking havoc in that area around it. So at least immobilize it so that it stops wreaking havoc in the area around it. And best case would be to get it reduced. They can do some reducing in the ED. Reducing it means putting it back in line. If you can't put it back in line, emergently, then the best thing to do is immobilize it and splint it till you can get to someone that can reduce it or put it back in line. After you immobilize it, then elevate it and try to reduce the edema and venous return. And we're always doing neurovascular checks of the involved extremity, and then, of course, surgery. For treating these complications, so if you're having large bone bleeding, again, just an extra slide, because if you are having massive hemorrhage or you're having low blood pressure or tachycardia from hemorrhage from a long bone fracture, if you can look, that pelvic space can hold 4 to 6 liters of blood. Our body, it can hold our entire blood volume in the pelvis space. So if your pelvis is bleeding, you can go straight into full hypovolemic shock very quickly. Your long bones, the femur space, can hold 1.5 liters of blood, so 1/4 of your blood volume. So you can see that long bone fractures, if they are bleeding, can cause hemorrhagic shock pretty quickly. And appropriate splinting can reduce the bleeding. So even if it hurts, we need to get that under control and stabilize the patient, and get them immobilized the best we can. If you do find yourself in hypovolemic shock, again, the treatment for it is fluids. It is a lack of fluids. So if you have a patient with a deformed extremity and a low blood pressure and a high heart rate and a high respiratory rate, you are in the compensatory stages of hypovolemic shock. If you do not intervene and replace that volume, they will end up in progressive or irreversible stages of hypovolemic shock. So at this point, as soon as you start seeing a high heart rate or a lower blood pressure or tachypnea, even tachypnea and a high heart rate, you're compensatory. As soon as your blood pressure drops, you are in progressive stage. So your immediate interaction on these patients is you're not suspecting sepsis on these patients right now. If they've been in a trauma and have a large bone fracture, you're suspecting hypovolemic shock, and you will treat them with fluids. Fluids and blood if you can. One other thing I'm going to point out in any bleeding patient of any kind is cold blood don't clot. Cold and acidic blood doesn't clot. And we will never get their bleeding under control if they are cold and acidic. So if you can warm the fluids or warm the patient, that would be best. If you're giving room temperature blood to a patient and you're giving them lots of fluids, you're giving them 2 or 3 liters and then probably 2 or 3 or 4 or maybe even more products. If you're giving them to them at room temperature, they're going to be 70 something degrees. If you're replacing their blood volume with 70-degree room temperature products or cold products, then they're going to become hypothermic pretty quickly. So something that we do when we replace more than 1 liter or 2 of fluid or blood is to warm it. And I do believe, I don't know if you ever saw Katie's rapid transfuser video, that she's showing block 3, the rapid transfuser video, but I don't know if you guys got a chance to see it. But when we give blood quickly, more than a unit at a time, it is supposed to be done on a fluid warmer. And that's to keep the fluids at body temperature. Yes, that's the level 1 machine. I'm not going to test you on the machine or anything, but just know that if you're giving more than 1 liter or 2 an hour, you should probably warm it, because if our body is only holding 4 or 5 liters of blood, and we end up replacing 1/4 or 1/2 of it, it should be warm. Because the least thing, we are just shooting ourselves in the foot by replacing at room temperature, because your clotting factors only work in non-acidic environments and in our normal temperature. They only work at normal temperature, normal pH. So if we end up giving tons of volume that's cold or room temperature, we're going to hypothermia our patient. And we don't want to do that. So when you're in hypovolemic shock, it should be, and you're thinking we're going to be giving multiple liters of fluid within an hour, it should be warmed so that we don't have hypothermia. Not just for patient comfort, but so that our blood clotting factors actually work. With compartment syndrome, know the 5 Ps. The pulselessness, poor cap refill, pallor, paresthesia, and pain not relieved. If your patient is having a large bone fracture or a bone fracture, when you give them their Demerol, their Dilaudid, their fentanyl, their pain should go down. Pain that does not improve could be a sign of nerve compression or compartment syndrome. You'll keep an eye on the extremities of any bone fracture, whether it's a large bone or small bone. Always check your neurovascular checks below the extremity because we're looking for swelling. Excuse me. And in this picture here, you can see how many compartments. If your bone has broken here and damaged this inner muscle, this inner compartment, it will swell, but it has nowhere to swell to. These compartments are rigid where our blood volume is if you have bleeding in here. And if it's swelling in here, all it's going to do is continue to swell and press on those blood vessels there, and you'll end up, the only sign of it is decreased perfusion to the leg there. So if you have compartment syndrome, you won't see it happening except for blood and nerve getting cut off. And that's because the bloods and the nerves all travel between the compartments. So if you have an inner compartment swelling, this outer compartment can swell out this way. This one can swell out this way. This one can swell out here and keep pressure off of those internal blood vessels and nerves. But this inner compartment here has nowhere to swell except into the blood vessels. So any fracture or damage to that internal compartment can cause compartment syndrome and decrease blood flow to the foot. The intervention for that is to cut down into that compartment and allow it to swell. So anyway, what you're going to remember about compartment syndrome is always check your neurovascular checks, which is the 5 Ps. You're checking pulses, cap refill, skin temperature and warmth, and making sure they can feel it. So if you've ever taken care of someone with a broken arm or a broken leg, when they're casted up, we're always checking the fingertips or the toes to make sure that they have good pulses, good cap refill, and that they can feel where we're touching them, because if they cannot, then that is a sign of compartment syndrome and you would need to notify. Pain not related by narcotics is also a early sign of compartment syndrome, and you would want to check for all the other Ps in addition to pain. Heat-related emergencies. Again, we live in Arizona. You've probably gotten this somewhere along the lines, Girl Scouts, Boy Scouts, kids, schools, wherever, typical first aid. But knowing the difference between heat exhaustion and heat stroke. Heat exhaustion, you are still sweaty. Heat stroke, you are not. You are dry. With heat stroke, you've gone past your compensatories. So think of heat stroke as you are no longer compensating. Heat exhaustion, headache, fatigue, weakness, but you have moist skin. You are still sweating. You may have a decreased blood pressure, increased pulse. You are still compensating, and you are trying to cool yourself by sweating. If you do not pay attention and treat yourself in heat exhaustion, you will fluid deprive yourself to the point where you are in heat stroke. The body cools itself by sweating, and if you have sweat away or you're dehydrated, and if you are dehydrated and cannot produce sweat any longer, then your body goes into heat stroke where the temperature is so high and it cannot regulate itself because you don't have enough fluid. So with heat exhaustion, this is a patient, they may or may not be coherent, they may be confused, but the difference is that they are still sweating. Their body temperature is high, but it is less than 105. So if your patient, you come across somebody who's laying on the ground, heat exhaustion, remove them from the heat and get them to rehydrate however you can. The priority is rehydration and heat exhaustion, getting out of the heat and rehydration. The rehydration will continue cooling. You could certainly help them cool by giving them ice packs, putting them in a cool area, getting them in front of a fan, a cool bath bath or shower, but the priority is rehydration and heat exhaustion so you don't become fluid volume depleted. In heat stroke, you've already lost all your fluid volume. There's no self-cooling ability, and the body temperature is super high. The problem is the body is cooking itself in heat stroke. So the intervention is to lower their body temperature first, stop the body from cooking itself, and then you can worry about rehydrating them, which is the proper treatment, but you need to get their body temperature down as well. Sorry, the thing went right in front of my chat box there. I see a question. When you start cooling these folks, do they ever seize? If your body temperature is super high, you can have febrile seizures. So you would still continue to cool them. They're not seizing from the cooling, they're seizing from the febrile, the fever cooking the brain. And that's what a febrile seizure will do. So I would not stop cooling them because of seizures. In fact, I would continue to cool them more. If they were seizing, I'd be worried about the febrile seizure. They will shiver, but they should not seize. So seizures would be from the febrileness. So I would say the difference between the two is with heat exhaustion, your priority is hydrating them and cooling them. But with heat stroke, your priority is cooling them first. We've got to stop the cooker. And because you don't have enough fluid to stop it on your own, we need to stop it. So this is where we would lower the body temperature with direct cooling first, and then if we had to choose one before the other, of course we could certainly start an IV and cool at the same time in real world. But in NCLEX world, where you might have to choose one before the other, in heat exhaustion, you will hydrate first, cool second. On heat stroke, you cool first, hydrate second. But of course, we know with both of them, we would want to do both at the same time if we could. Hydrate and cool at the same time. But in NCLEX world, heat exhaustion, hydrate, then cool. Heat stroke, cool, then hydrate. Does that make sense? I just want to kind of point out that difference there. And the reason we cool and then hydrate is because they are cooking in heat stroke. And a cooking brain doesn't do very good. Cooking body, cooking heart cells, we don't need to be cooking our body. It won't work for very long. So get it cooling and then worry about the hydration. Of course, when they come into the ER, you're doing both at the same time. But if it comes to an NCLEX question, that's the difference. Hypothermia is any core temperature, I think less than 96, sorry. Typo. I'm trying to catch my typos. I'm not perfect. Anything less than 96. Because mild hypothermia really starts technically at 36 degrees, which is 96.8. So core temperature less than 96. You could be mildly hypothermic, and really the only symptom you should have at mild hypothermia is shivering and probably lethargy. We shiver to get our heat generated and to get our heat back up. Moderate hypothermia is when you have dropped down below 34 degrees and the shivering has disappeared, diminished, and this is where you start slowing things down. You get bradycardic, you get a slower respiratory rate, your body metabolism has slowed down so much it doesn't need a lot of oxygen, so you get a slower heart rate, slower respiratory rate, your blood pressure actually drops out quite a bit, and you do end up acidotic because you're not providing enough. But if your body slows down enough, you don't end up, it's not severe acidosis. Into severe hypothermia, which is a temperature less than 30 degrees Celsius, 86 degrees. This is where you can actually appear dead. Oh, I did look at this. I even figured out what agonal respirations were, respiratory rate less than 6. I should have just listened to myself from a couple of weeks ago. Apnea or agonal respirations, respiratory rate less than 6 is considered agonal. Profound bradycardia, asystole, they can even be in VFib, but you cannot declare a patient dead, no matter how dead they look, until you get them warmed to normal temperature. So you need them at least at 36 degrees to declare a patient dead. So even if they are dead and they have no heart rate and no respiratory rate, you have to warm them to normothermic before you can declare them. So that is why when patients are pulled out of frozen lakes, they may appear dead. They arrive in the ED, and they have to be warmed before they can be declared. So the things I want you to point out on hypothermia is that at mild, you have shivering. At moderate, you do not have shivering, and you're now into bradycardia and low respiratory rate, low blood pressure. And at severe hypothermia, you can appear dead, but you need to warm the patient to declare. The intervene is slow rewarming. We can't just pound a bunch of warmth at them. We want to control the warming process. You can cool a patient as fast as you want, but to warm them, it has to be slow. There's a lot of fluid shifting going on. We don't want to ramp up the body too fast. Causes a lot of electrolyte imbalances, fluid balances. So we want to rewarm them, and no more than half a degree Celsius an hour. So if your patient comes in 30 degrees, it's going to take you how long to get them to 36? If you're warming them appropriately. 12 hours, a full shift. So this patient will be slowly warming for the shift, and you will, you will get them warming to see if any. Now, if they are not coming back as you warm them, they may declare death at maybe 34 degrees. But you do need to get them at least into the mild hypothermia range to prove that they're not anything going to come back. So they will slowly rewarm them. You don't want to rewarm someone more than half a degree Celsius an hour. Warming them faster than that will cause a shock to the system. So you can rewarm them any number of ways. Warm blankets, forced air warming. This guy is the air warmer. You can wrap them in this is a warming blanket. This one down here is a warming blanket with warm air going into external blankets, so we have warm air circulating all around the patient. You put these little chest things and feet things around them, and you can warm them and cool them both ways. But you can decide warm water or cold water to warm or cool your patients. You may have seen some of these being used as cooling blankets, warming blankets. Either way, this will use external liquid warming all around the patient. This one provides air. This one's amazing. Sometimes I use these myself. This one's putting warm air into this little blanket that has little holes throughout it, and you can warm a patient that way. You can also put in a catheter that goes into their femoral or central venous circulation, and can warm, like basically the blood rolls past a warming coil, and as the blood goes past this warming coil, the blood warms up. So you can have internal, we have warmed IV fluids too, but there's also an internal coil that can warm and cool a patient as well. So there's lots of different ways to warm a patient, but the important thing is that you're monitoring their temperature and try not to get them more than a half a degree an hour as a warming. Reduces complications of warming. What else do we have on here? Frostbite. Frostbite we're going to treat like a burn. And we might get to burns next week at the beginning of the class. You certainly have the lecture. I will probably do a voiceover over it so you can look at it during the week. But we'll review burns at the beginning of next week. We're treating frostbite. Frostbite is a burn. It's ice crystals in the tissues that are actually act as a burn to the tissue. And so we would treat it as we would a burn. You either have superficial or deep frostbite, which is the same as a first or second degree burn, and then a deep one is a third or fourth degree burn. The intervention for frostbite is to put the extremity into warm water, not hot water, warm water until the circulation returns, and it is very, very painful. Don't scrub or massage the tissue. The tissue is actively going through changes and is actively burning as it's cold, so we want to get the tissue warmed up and get those ice crystals melted out of the tissue. You won't see the development of frostbite for about 24-48 hours. It continues to burn just like a real burn. Anyway, so we'll talk about burns. So treat frostbite like a burn, except for the fact that we're going to put it in warm water. Measure the temperature of the water. Make sure it is a little above room temperature. I think even 104 would probably be a little bit much. That's kind of hot tub kind of water. This patient cannot sense the temperature. Have you ever had cold hands? You come in from a cold day. I mean, it's probably not as common in Arizona, but if you've gone up to Flagstaff or you've ever been anywhere in the snow and you put your hands under cold water to wash them and it feels warm, your sensation is messed up. When your hands are that cold, your sensation is displaced. You can't tell warm from cool. You don't know. You cannot ask the patient to tell you the warmth of the water. They can't tell. You have to get the temperature of the water before you put the extremities in the water, because the patient will not be able to sense properly the temperature of the water. So if you've ever done that, go put your hands in the freezer for about 2 minutes, and then go put it under cold water, and it will feel like it's burning. Your sensation, your nerves are confused, they're messed up, and so a patient cannot tell you if the water is too warm or too cold. You have to test the water and get the temperature yourself, and then give it to the patient when it's the right temperature. Do not ask them, is this too hot? They won't know. So your nerves are messed up when your hands get too cold, and with frostbite, it's definitely more so. Drowning we're going to treat as respiratory failure, but what I'm going to point out to you is that if you submerged and you have water in your lungs, it's treated as respiratory failure. It's treated as pulmonary edema. It's treated as any respiratory failure would be treated. But secondary drowning is also known as dry drowning, and that is actually a full-on pulmonary edema or ARDS response to aspiration of water. So you can have dry drowning where, you pull kid out of the pool, they cough up water, they're breathing fine, and then in 2 to 3 days they have a full-on pulmonary edema ARDS effect. And that is basically, it's due to drowning and it's due to an immune reaction, but an actual drowning is considered death from suffocation. Submersion injury is called near drowning or a survivable drowning incident, and that is due to actually the lungs being full of physical water from the pool or lake or wherever it is. Secondary drowning is dry drowning, which means that you were in a drowning situation, you appear to be okay, and then 2 to 3 days later, you end up in massive pulmonary edema and respiratory distress. It's called dry drowning or secondary drowning, and it actually is very similar to ARDS. The signs and symptoms are very similar to ARDS. Immersion syndrome is another word for hypothermia, and that you're in water that is not body temperature. So any water, even 70-degree water, can cause immersion syndrome, which is hypothermia due to being submerged in cold water. So a lot of patients that are drowning have both a submersion injury and immersion syndrome, which is hypothermia going along with their hypoxia. Anyway, we're going to treat it, though, as we would treat any respiratory failure. It's going to get 100% oxygen, CPAP, BiPAP, mechanical intubation, treatment for ARDS, all the same treatments as respiratory failure, and we would also warm the patient less than 0.5 centigrade an hour. So drowning therapy is basically respiratory failure therapy. So you can kind of go through all this, but it's respiratory therapy and rewarming if hypothermia is present. And then the toxins. The ED nurses dealing with everybody who wants to put everything in their system. what we're going to do is the first thing. So I want you to remember these key points. I don't want you to memorize. So after here, there's tables of stuff. I'm probably not going to spend a ridiculous amount of time testing you on the tables, because the treatments, and that is like the 5th treatment, the first 5 steps, the first 4 steps are the important steps of you have an exposure to a toxin, whether you meant to or not. If it's a toxin, it is something that is poisonous. If it gets into your bloodstream, can cause adverse effects, respiratory or circulation-wise. So poisons, toxins, overdoses, biological terrorism all fall into this toxins overdose category. What we're doing first is trying to figure out what the patient was overdosed or toxined on, trying to identify the poison or the toxin. So when the patient shows up with stuff or EMS is called, that's usually the first thing they're doing is trying to figure out what did they take or what were they exposed to. The amount ingested, the time ingested is very important because it helps us figure out what kind of therapy we're going to be doing for it. So this works for, like I said, overdoses or toxin exposures. And we will do urine, blood, gastric content analysis to try to figure out what it is if the patient or someone can't tell us. If you roll up to somebody that is overdosed and they can't tell you what they overdosed on, you can't figure out at the scene what it was, then they will do urine, blood, and gastric content analysis to try and figure out what got into their system. The toxin-specific treatments are run by the Poison Control Center. Our treatments here are general recommendations, but Poison Control Center should be called on any overdose or any toxin exposure to make sure that we are doing the right treatments. So your first part is really figuring out what the heck happened to this patient, see if there is a potential. So technically we're counting COVID as a toxin at this point. If you are exposed to COVID, we need to see if there's a potential exposure to healthcare workers or to bystanders. If you're exposed to a certain gas or a biological terrorism thing, an overdose of a patient taking too much stuff is not going to cause an exposure to bystanders, healthcare workers. But if you are exposed to a toxin or a radiological thing, we have to make sure that everyone is safe. So part of the first thing is just figuring out what it was that has led you to these symptoms. If we know it was an ingested overdose, and we can find out what the cause is, we find out how much and when it was ingested. So assessment and figuring out what the toxin is and how it was ingested or how they were exposed to it. The second thing is decontamination. So if it is something on the surface, so a toxin could be an acid, antifreeze, drain cleaner, whatever people decide to put in themselves or expose themselves to could be a toxin. We'll try to decontaminate the patient to the best of the ability. If there's exposure to the outside, direct irrigation, you can irrigate eyes, skin, you can irrigate the bowel by putting in what we'll talk about an OG tube in a minute, but decontamination means flushing out the system. Most of that is done IV-wise, because if we're going to do rapid IV irrigation with almost any toxin, because it will help flush the toxins out of the bloodstream if they do arrive in the bloodstream. So if it is a surface thing, like an acid or an exposure, or something on the surface of the skin, directly irrigating. Otherwise, we do most of our irrigation with IV irrigation to clear out the bloodstream, to keep blood flow moving, to keep things going through the kidneys and the liver to get rid of that excretion. So decontamination, so we're going to probably start IV fluids on any overdose patient. Emesis induction is useful if the toxin has been ingested within 1 to 2 hours, because of course your stomach empties after about 2 hours. If you're going to induce emesis, they usually do it with ipecac syrup, but there are some contraindications for emesis. Ingestion of a toxin more than 4 hours, that toxin has moved out of the stomach and is into the intestines, and probably emesis is not going to do a whole lot of good. Airway disease or altered mentation. We're not going to have someone throw up. that already has a problem with their airway or altered mentation because they can't protect their airway and they could aspirate. So we're not going to induce emesis on anyone with altered mentation, ingestion of a toxin more than 4 hours, or ingestion of a corrosive or caustic agent. So something that, oh, it's gone again. Okay, I'm back. I think my, I'm going to have to figure out, my transmitter keeps going to a power save mode. I'm back, right? Give me a holla, yes? Okay, good. So emesis induction, like I said, we're not going to do it if you have ingested the toxin more than 4 hours before, because it's probably gone from the stomach. If you are at risk for aspiration, or if you have ingested an acid or a corrosive caustic agent, because it will do more damage on the way back up than it will if we just leave it where it is and try to flush it out another way. So those are the contraindications to emesis. So like I said, knowing when the toxin was ingested is important for that, because they may bypass emesis and go to gastric lavage. Gastric lavage is ingestion of a toxin within 12 hours, because we can get that remnants out of the stomach, and some of that lavage can get into the intestine we can do the whole bowel irrigation with gastric lavage. Ingestion of a toxin within 12 hours, patients at higher risk for aspiration, because we're doing it controlled through a tube. Gastric lavage is done through an orogastric tube or a nasogastric tube. So if you are at risk for aspiration, if we do the lavage, we don't want you just vomiting it up. We can actually control getting the stuff out of the stomach. So gastric lavage is far more preferred than inducing emesis almost on any patient. But like I said, you may be asked to induce emesis at some point. But gastric lavage is safer, more controlled, and probably more often indicated than emesis. There aren't as many contraindications to it. You put the orogastric tube in, you can lavage the stomach and the intestines and then suction out the contents. If activated charcoal is indicated, which is our next step, it can be given through the OG tube. So you can see that probably most overdose toxin patients are going to land some kind of NG or OG tube to help lavage out the gastric system and provide the binding agent that is called activated charcoal. Activated charcoal is not your charcoal briquettes. It is specially formulated charcoal, and what it does is it's usually combined with a laxative. It's usually a liquid injection. It's given orally. They do have activated charcoal tablets, but they do most often give it as a liquid, and you can take it orally or do it through an NG tube or an OG tube. But what it does is it traps the toxins in the gut and it prevents their absorption, and then it's excreted out. The sorbitol will actually really push. It's an osmotic diuretic. I mean, not osmotic diuretic, osmotic laxative. And so it will pull water out of your systems and flush and basically do a whole bowel irrigation. It pulls water out of your bloodstream and sends it out through the feces. So watery diarrhea can cause dehydration, but we are also irrigating the vessels with fluids. So we're providing fluids to the vessels, and we're actually pulling things, we're pulling fluid, we're binding stuff in the gut and actually pulling fluid from the bloodstream and causing this whole bowel irrigation. So it's kind of how you do whole bowel irrigation is you can put water down the gastric tube, put the activated charcoal in there with the sorbitol, and that all pass through the system. And that will basically try to pull any toxin that is left in the gut, so any meds that you accidentally took, any acids that you swallowed, any caustic agents. God, people can put anything in their mouths. And if it is a toxin, they will put down that OG or NG tube and lavage out the stomach, and then send activated charcoal down the rest of the intestine to kind of clean out the rest of the intestine. So that's kind of a quick overview on the quick treatment of what we do for most overdoses. especially if it's ingested. Gastric lavage is the key. I would say emesis induction. I would kind of go to my ED peeps there who work in the ED and say, how often do you see emesis versus gastric lavage? Really, our key components of therapy for any ingested overdose are going to be big time figure out what toxin it is, IV fluids, and then we'll probably go, this is a questionable thing. We can do the same thing with gastric lavage. So I'm going to say they probably, in most EDs now, go straight to gastric lavage instead of emesis induction. And then they will, so for most ingested overdoses, it's going to be IV fluids, figuring out what it is, giving IV fluids, getting in that NG or OG tube to do your gastric lavage, and giving activated charcoal. Once you figure out what it is, you can find there's antidotes to most common overdoses. You can always hemodialyze anything that's gotten into the blood and is a toxin. So most overdoses are usually handled after, if it's not ingested or if it was inhaled. We probably wouldn't do the OG tube and the gastric lavage, but most toxins are ingested, and that's why gastric lavage and the activated charcoal works for anything that's ingested. It gets it out of the GI tract. If someone's overdosed on benzodiazepines, there is an antidote, and I guess what I would say is maybe know the name and be familiar with the antidotes for the most common classes of meds. I don't need you to know all the vital signs, and maybe you could make little badge buddy cards or shrink this. I don't know. I had a good time putting it together because I thought it was really good information. But in terms of testable information, maybe know the most common antidotes. Because if someone's overdosing on benzos or you give too many benzodiazepines, the antidote is flumazenil. It will reverse the effects of the med. Tricycline antidepressants, they give bicarb, they alkalize the system. And again, you can look up all the reasons why these are what they are, but I think it's just nice to know the antidotes for most major things. Acetaminophen, you'll give acetylcysteine. So once you've gotten the gastric lavage going on, they'll give the antidote to whatever it is. Gastric lavage, activated charcoal to get rid of it out of the gut and keep it from getting absorbed. And then for whatever did get absorbed and get into the bloodstream and is affecting and causing symptoms, they'll give the antidote for. And that's kind of the fifth step. The first one is to prevent more of it from getting absorbed by getting it out of the GI tract, and then dealing with whatever's been absorbed by giving the antidote. So I will let you go through all these, and this is where I did a different colored slide for the bioterrorism agents. Again, these are not things that you choose to ingest, but could be ingested. Things that are used as bioterrorism agents are actual, just regular viruses, bacteria, and can be used harmfully. So I put the most common biologic toxins there. And if it's bacterial, it's going to get antibiotics. That's why nobody really freaks out when they hear about the plague popping up in Flagstaff. They're like, oh my God, they had the case of the plague. Who cares? It's a bacteria. Give it antibiotics. It's fine. We have that technology now. It was a big deal back before antibiotics in the 1940s, but before that, it was a big problem. But now, okay, you got the plague, you get a biotic. It's a bacteria. So most bacterial things would get treated with antibiotics. Tetanus is a bacteria. It's not a biologic toxin, but it does get into wounds, and there is a vaccine for that. Botulism, there's an antitoxin for. So just basically one-liners on these guys. Just what is it, and what is its antidote? Cyanide is a potential terrorism agent, and I gave you kind of some very quick signs and symptoms of it, and their antidote. So I would just say probably big overall things, guys. Just recognize the name and possibly know the antidote for it. And again, these are inhaled. most of these, I think the mustard gas, sarin gas, ricin, depends on, they can be inhaled or ingested, and the treatments are there. I don't spend a lot of time on it, but I know NCLEX does have a couple of bioterrorism questions. I'll probably have one or two, and they will be along the lines of, what has an antidote, what does not. You're only familiar with ricin from Breaking Bad. Yeah, it's from castor beans. I think, isn't that the toxin from castor beans or some kind of beans? So yeah, it's a toxin that goes in and basically kills your proteins in your cells and inhibits cellular functions. And it is actually you can eat it, you can be given it, or you can inhale it. And so it has different symptoms, but depending on how you do it. Inhalation injuries, basically, we're just treating the damage to the lung, so treating it with respiratory failure. Any toxin's going to get IV fluids to try and mitigate the toxin and help flush it from the system. Any sort of toxin's going to get IV fluids. If it was ingested, it'll get probably some kind of gastric lavage, activated charcoal, and then, like I said, the antidote. And so if there's no antidote, you're just going to symptom treat it and do the best you can at keeping it from getting absorbed. So I think that was enough on the ED. I can do a voiceover on the burn lecture during the week sometime. I could probably do it this evening real quick, a quick voiceover, and then post it on the module.